Well, good evening and welcome to NBS Extra. This is the Political Command Center. My name is Dalton Kawesa. Yes, like you've just heard, we're going to be discussing infrastructure and health. What is your take? What has been the commitment by the different governments? And this time, we're not just talking about the region, rather Uganda particularly. We're also extending the tentacles to the East African or the whole of the Gulf. And I have three gentlemen in the studio and a lady. I will introduce one by one, and my extreme right is Miss Ganawe from Ethiopia. He's Executive Director, Save the Nation Ethiopia. Welcome to the show.
Thank you.
I have, just next to Mr. Ganawe, we have Mr. Mutuza, if I get it right, and is the Senior Policy Analyst for DATE at Africa Forum and Network of DATE and Development. Good evening.
Thank you.
Then I have Diane Tibesigwa, a Policy Analyst from World Vision. Welcome.
Thank you.
And finally, Julius Kapepo. What does this one mean? You can break it down. You sound to the coast of Tanzania.
Kapepo means the blessed one.
Okay.
Julius means Julius.
All right. Thank you and welcome to the show. And we're looking at financing alternatives for infrastructure and universal healthcare. Healthcare and infrastructure has been a big debate in this country, and I presuppose it also a big debate from Tanzania and where you come from, Ethiopia. Let me begin with you. Give us the status of in terms of funding for health sector and also infrastructure, please.
Thank you for having us here.
Yes.
And just to share that Ethiopian government has strategies that put under, and the government is trying to address health for all citizens in Ethiopia, and just organizing communities in each regions to finance their own health, which is they contribute every year. They saved in a bank where the government established. So within just a little amount of money, people could able to go to and get medications. And that system is not coming to the urban area, but in the rural areas, the farmers could send their children to the hospitals, clinics, and could manage to, keep their health.
Oh,
yeah.
Better. Okay, let me come into Vagani. From what you've heard, there's always this conversation about Abuja Declaration, 15%. What has been your experience in your country?
Yes. AfroDad is not only a Zimbabwean civil society organization, but it's only based in Harare, Zimbabwe, but we work across a number of African countries.
Oh, that is interesting.
Yes. So the experience we have had in terms of...
So you can give us a regional perspective,
yes,
when
exactly.
in your scope.
No, that's true. Thank you very much. Yes, the Abuja Declaration requires that governments allocate 15% of their annual budget toward the health sector, and I'm sad to report that they have been failing to do that. So there is a huge deficit in terms of health funding. So you find out that with the help of development partners, especially donors, in a number of countries, they've chipped in to provide health clinics, to provide access to medicines, and also to provide trainings, whether they are nurses and doctors. So there's really a huge gap in terms of what our governments are able to do to provide cheap and accessible health facilities, medication, training of nurses and doctors. So with the help of development partners, I think we have seen that in a number of African countries, the situation have been not that bad, so to speak.
Okay,
yes.
Before I come to Diane, let me come to Julius. There's this speech about, he highlighted about Abuja Declaration. Government, if you look at Uganda, is performs around 6.5 or something to do with the budget financing. Following the money, do you think the 6% has worked? 6.5%.
Yeah, thank you.
I think Uganda is a country that is also struggling, just as Thierry from Zimbabwe has indicated, just like some other countries across Africa, across this continent. In terms of performance, we've seen a bit of relative, what we'd call progressive improvement in the ambition of delivery of healthcare services and goods. If you looked at the spread of the health facilities across the country, the situation is better now than it was in 1980s, as it was in 1990s, as it was yesterday. Today we are better off. If you looked at the equipment that has gone, say, to supporting laboratories, the microscopes across the country, the detergents that we need to use, the test kits for malaria, for HIV/AIDS, for a number of these diseases, we are better off as a country than we were yesterday generally.
Okay.
Of course, we also still face a number of challenges along the continent, and also this is also coming within a context that if you looked at health sector in Uganda and a number of African countries, you will notice that a huge chunk of the sector resources, finances, actually come from the donor world. But this is also coming at the dawn of the reality that the global economy is a bit shaky now than it was yesterday. If you looked at the Eurozone as an example.
Maybe, Julius, before we dive deeper into the funding that is highly foreign, I want us to do a surgery of what is at stake. And let me bring in Diane here. Diane, from your organization, World Vision, we're known for extended tenterhooks across, especially when it comes to this country, and maybe across the board, but let me focus on this country. What are some of the intriguing issues you have met in the health sector in your quest to provide services and help people out there?
Okay, thank you to the listeners. Of course, the health sector, for example, in Uganda, they have a goal as the health sector, and that goal, they are looking towards having equitable, accessible, and quality health services in Uganda. And of course, they are informed by policies, the development plan, SDGs, the national health policy, and all these, they translate into the services that are provided by government. And you know, the services are stimulated or activated by the resources that are provided by government. If you look at the structure of our government and how funds flow, we have resources that remain at the central government, and then some resources go to local government. But we have had challenges, for example, us who do a lot of work in local governments, that they are limited by resources to enable them deliver the quality of services that we actually talk about. Because, for example, if you talk about primary health care, for a number of years we've been talking about primary health care funding towards these health facilities, and it has been minimal. So the services that local government have not really worked out well, and we have been out there talking to government to increase funding towards these areas. Okay. So while World Vision comes in and other partners to support the sector, we still have challenges of staffing, drug stockouts, the infrastructure itself cannot, like the state that it's in, cannot enable us have the quality of services that we're actually talking about.
Okay. Okay, let me bring in Thierry Vangani. You seem to have had research on how far the different countries have performed in your region, let's say Southern Basin, in meeting the 15%, and you say they have not. There is a temptation to push governments to achieve the 15% Abuja Declaration. But there's also the other argument that there are so many, there's Maputo that calls for 18%. When you look at this declaration, it's more than 100. Where is the balance? Where should we achieve the balance?
Yeah, I think it's very important that we understand that the government have an obligation to provide quality health services to its citizens. Yes, we can differ in terms of these figures, but these are just benchmarks for countries or targets that governments set at these levels, like the regional protocols or these targets. They are at the regional level, they are aspirational. But me and you know that there are so many challenges within our governments when it comes to funding. And there are a lot of gaps within the infrastructure that angers the health service sector, for example. During the conference, we have been talking about the need for infrastructure within these sectors. For example, provision of clinics, provision of quality trained personnel within the health sector, and also access to medicine. We need the factory, the pharmacies to produce quality medicine so that people have access and are able to get the services. Okay. So it's more than the figures we are talking about. There are a lot of other issues that are interrelated. For example, the roads. We need the roads for people to be able to travel to these health service centers. We need energy, power, so that services can be provided in a better way. So it's more than the figures.
The figures, yes. Are those that are just joining us, we are trying to understand is a Pan-African Conference on Public Financing for Health and Road Infrastructure in Africa. And the theme is about reducing on the borrowing as we find alternatives to finance these sectors, which are very critical in the development of any country. Let me come back to you, to Ms. Gavani. All of us agree there are gaps in our respective countries. Yeah. And this brings to my question, especially to you. Where do you benchmark on? Because in order to address the gaps, you must benchmark. Yeah. What are your benchmarks in order to fix the gaps in your country?
You mean in the road infrastructure?
Yeah, it's still in health, because health is very critical here.
Yeah. In Ethiopia, the government is financing 35% of its road infrastructure. You know, we have state-owned companies that are.
Now, before we go into the infrastructure, let's first focus on the health sector. Yeah. So what are the benchmarks? How do you arrive at them in the health sector in your country?
Yeah, there is an ambitious plan in Ethiopia that government want to address healthcare for all citizens, and they are working on it. And they put in 2030 to address this issue. You know, people could to let people have the health care insurance. So within the system that I have mentioned earlier, that people could contribute a few amount of money so that the government subsidize that, so people could secure their health care. Yeah.
All right, Julius, let me bring in here. Since you're front runners of this conference under Uganda Debt Network, and you've been very instrumental through budget processes and giving alternatives, from what you hear from them, I know you have picked a leaf from where they come from. What are some of the things that this country can borrow from their practices in the realm of health?
Yeah, what we've done as Uganda Debt Network, with support of the Democratic Governance Facility and the Dan Church Aid, is to bring a number of African actors to a conversation in Entebbe, Uganda, today, tomorrow, and into the weekend. From Ethiopia, from Zimbabwe, from Tanzania, Rwanda, Ghana, Kenya, and out of that, then we are having the benchmarking in the first place that you are talking about. What are the lessons? What are the experiences? How has Rwanda done it? How has Ethiopia done it? How has the other one done it? So that is one level. The other bit is, if we took an example of Ethiopia, since you've just referred to the Ethiopian experience, in terms of having budget resources, money comes kind of ideally on two fronts into the coffers. One, domestically generated resources. When there is a gap, then you run to borrowing. In some of the cases in Africa, even before they notice the scale of the gap, the default mode is to run for someone else's money. Yet ideally, you should first exhaust your own possible domestic resources, tax and non-tax revenues, into your coffers. And then if there is any gap, then you think of options. One of the options could be scale down your ambition. The other one could be do gap filling, in which case then you would use loans. In the case of Ethiopia, one of the strategies to getting resources into the national budget has been to have state enterprises. In the case of Uganda, with our full liberalization policy in the 1990s, and Ugandans can bear me witness, we are interrogating that kind of policy regime. If you looked at a case of ESCOM, which has come into Uganda to run sections of the power sector, ESCOM is actually a South African state enterprise. But here in Uganda, it is kind of perceived that everything that is Ugandan, the Ugandan managers cannot manage. It must go to private entities. But ESCOM has actually come, which is a state enterprise, into the Ugandan power sector. The other bit is that if you looked at some of these enterprises which have been privatized, whether Uganda Commercial Bank, which we still are concerned about, if you're talking about financial and revenue mobilization for purposes of the budget. If you look at Umeme as a case, those companies are actually being ably managed by Ugandans, and they are profit making. So in the case of Ethiopia, if you looked at the Ethio Telecom, which is a communications company, in the Ugandan case, it would be like Uganda Telecommunications Company. Financial year that has just ended, 2018-19, they made a profit of $1.25 billion for the Ethiopian people. Even if we assumed that that was gross and profit was just half, that half of $1.25 billion goes into the state coffers, and out of that, then you have the capacity to say, let this money go to health, let this money go to whatever infrastructure and other budgetary needs. So one of the ways is that we need to check whether we should not rejuvenate some of the enterprises and have them as state enterprises that are owned by the people of Uganda, by the people of Zimbabwe, by the people of Ghana, for purposes of profit. We also need some of the areas that are strategic in investment. If we talked about the healthcare, for instance, you can't simply privatize 100%. Then the social being and caring for the low-income earners in your country, the Mwananchi, becomes a big issue.
All right.
So those are areas we could
Diane, you've been quiet for so long. Let me bring in you here. Away from rejuvenating the state enterprise, as Julius highlights, there's also conversation on PPP, a public-private partnership. From your own take, you say there are gaps, staffing gaps, there are so equipment. Do you think if we broke this conversation of PPP, public-private partnership, the whole sector will be started?
The private-public partnership.
Yes.
It's important that we actually have it, but we should also cautiously tread around it. While we promote the public-private partnership, we should not forget that if a country does not come out to regulate it very well, we may lose the social rights to the citizens who are actually supposed to benefit from these services. Yes. So we need a country which is going to promote public-private partnership, but it should also come out to kind of regulate on how this partnership is going to be. Right now, we are into the process of developing the National Development Plan 3. And there are around 6 strategies that the development plan is looking at. And they're highlighting issues of private-public partnership as a way of improving social services, including health. And government is not committed it does not show its commitment on how actually the PPP is going to be implemented in this case. So while we really want to have the PPPs, because we should not start advocating around government to establish new health facilities, yet we have the private sector in Uganda which can actually equally provide the services that we need. So we need government to sit down with the private sector and agree on how best they can deliver these services. But one thing that I want to put forward in terms of public-private partnership is that government should not forget its role. It needs to take the front seat and drive social services, the health services that we are talking about. Then the private sector comes in to actually contribute towards it. So the regulation and the regulation of the private-public partnership is key, and then how the whole terms of reference with private partners, they need to discuss it so that we don't leave it to private sector, because that's where the issues of high prices come in. I mean, the high prices that people cannot even afford. That's why you see our out-of-pocket expenditure is around 41%. You get it? So people cannot afford healthcare in Uganda today. So while we are trading the public-private partnership, we need to put that into consideration.
Well, Trivangani, definitely I'm going back to you to give us an experience in the region, in that southern basin of the public-private partnership. What is the story? And perhaps from Ethiopia, we'd also love to hear whether it has borne fruits or it's a white elephant. Let's go for a break, and when we return, the conversation continues on the public financing of not only infrastructure, but also health sector. My name is Dalton Kawesa. Stay here.